This conference will now be recorded.
Aman,
Yes, sir.
are you guys ready?
Yes, sir.
Yeah. In our last class, we have discussed about the what about how the diabetes occurs and what are the types of diabetes and how how it will be maintained and the pathways of diabetes and all those things. Now we will be discussing about the presenting problems in diabetes. So what happens if most of the time the patient will comes with some other vague symptoms, and we investigate the patient regarding that and then we will be detect and there will be raised sugar levels. So that is a so in these patients will be again these patients will have twin minds, because they don't know they are diabetic, but on your routine examination it will come as the patient is having diabetes. So the patient will be telling that no, the report is wrong. Most of the patients, once they detected as diabetes for the first time, they will straight away tell that no, the report is wrong. So there will be this occurs in most of the patients, but in patients who are having the symptoms, so they will tell us what to do. And they will ask the most of the patients who are educated, they will be asking that okay, diabetes is detected for the first time. If you say them that diabetes is detected for the first time, they will tell you that they will ask you whether what to do and how to proceed further and how do you confirm and all those things. And what are the symptoms? Usually the patient presents to the OPD with which what symptoms the patient will be having, and which what symptoms the patient presents to you. You should suspect the patient is having diabetes, that is hyperglycemia. One is thirst, that is excessive thirst and dry mouth even after excessive drinking of water. Then also there is dry mouth, and patient complains of frequent dryness of mouth. That is the first symptom. Other one is polyuria. Usually the patient complains of need to go to a washroom 4 to 5 times during my night time and all those things. And increased frequency, and sometimes increased frequency and increased number of times the urination. And again the second thing is nocturia, that is polyuria nocturia. Other one is tiredness and easy fatigability. Lethargy means loss of interest to do things, and early tiredness, and also fatigue, easy fatigability, that is unable to do the work and all those things. And other one is change in weight. Usually there will be weight loss. Weight loss occurs in the patients of type 2 diabetes mellitus most commonly. And blurring of vision. This blurring of vision and this pruritus valvae and balanitis, these are due to these are the most common complications due to uncontrolled diabetes and prolonged diabetes. It is prolonged hyperglycemia. There may be nausea, headache, or sometimes there is mood changes such as irritability, difficulty in concentrating, and apathy. Apathy means disinterested to do anything. And sometimes hyperphagia and predilection for sweet foods. So patient consumes more of water, more of food, and more water, more food, and usually goes for polyuria, but there is history of weight loss. So the triad of diabetes is usually polyuria, polydipsia, and weight loss. Next, coming to what are the key goals. What are the key goals is, so once the patient is diagnosed as diabetes on routine examination, first thing is we have to establish whether it is diabetic and whether it is diabetic or not. If diabetic, then what is the type of diabetes, that is type 1 or type 2. Once you confirm whether the patient is having whether the patient is type 1 or type 2, then it should be treated. So it should be treated accordingly. That is, type 1 patients should be kept on insulins, because there is loss of beta cells in these patients, so the insulins won't be secreted in these patients. Next, how do you establish the diagnosis? So based on the routine tests, the patient's glycemic status can be divided into 3 categories. That is normal, that is euglycemic; impaired, that is pre-diabetes; and diabetes. So how do you define them as euglycemic or normal, or euglycemic, impaired, or diabetes? So the glucose cutoff of these patients defines diabetes and is based upon the level above which there is significant risk of microvascular complications. And so the the definition itself says above which level the glucose concentration that is present in the blood causes complications that to the patients, that are either microvascular, mostly followed by macrovascular complications. The pre-diabetes can be diagnosed either as impaired fasting glucose based upon fasting plasma glucose result, or impaired glucose tolerance. So how do you diagnose them as diabetes or pre-diabetes? So patient is subjected to glucose load, that is patient is given 75 grams of glucose, and immediately before giving this 75 grams of glucose, the blood sample is taken and it is assessed. So if fasting plasma glucose is around 126, then it is known as impaired glucose. So what is pre-diabetes and diabetes means? If the normal value of fasting blood sugar is, what is the normal value of fasting blood sugar?
70 to 110 milligrams.
Yeah, 70 to 110 milligrams per deciliter. So if this value this fasting is 70 to 110, then patient is euglycemic. And if the value is 110 to 126, then the patient is labeled as pre-diabetic. And if the fasting plasma glucose is more than 126, then he is labeled as diabetic. Okay. Then what after that, patients with pre-diabetes should be advised to these patients who are pre-diabetic should be advised to take the precautions so that their progression to diabetes is cut short, and they should be we should advise them to give advice regarding lifestyle modification, that is, so there will be reduced chances of risk of progression to diabetes and other complications related to diabetes and hypertension. So if there are any risk factors for cardiovascular and hypertension and dyslipidemia, these should be also be maintained aggressively, so that to prevent the further complications. So in some patients there will be abnormal glucose value that is observed during a burden over pancreatic beta cells, that is during pregnancy, infection, myocardial infarction, or stress. And sometimes during most common drugs that causes diabetogenic drugs, such as corticosteroids. So in cases of temporal arteritis and all those patients, you will be given corticosteroids as treatment. So in those patients also there will be increased levels of glucose secretion. So there will be increased glucose, so that it is due to drugs. So this term is known as stress hyperglycemia. The term stress hyperglycemia is occurs that glycemia, the hyperglycemia that occurs during a stressor period. That is such as pregnancy, any infection, or any mental stress, or physical and stress and infections all is stress hyperglycemia. Once the stress is gone, the hyperglycemia, it may proceed to euglycemia, or it goes to the diabetes continues. So blood glucose should be remeasured, and oral glucose tolerance test will often show persistence of impaired glucose tolerance. So once the diagnosis of diabetes is confirmed, other investigations should include the plasma urea creatinine and electrolytes. So why this plasma urea creatinine and electrolytes? Because most of the cases of type 2 diabetes, they present 4 to 5 years lately, and the microvascular complications such as nephropathy, retinopathy, and neuropathy, peripheral neuropathy, they progress before the clinical onset of diabetes is detected. So to exclude the complications, there are microvascular complications at the time of in the form of nephropathy. So you have to measure the plasma urea, creatinine, and electrolytes. So lipids should be measured, because in most of the patients of diabetes will have hypertriglyceridemia. So and liver and thyroid functions to be measured to know whether liver what is the status of liver functioning. And urine testing for ketones, usually the ketones are usually present when there is high sugar values. So that chapter of diabetic ketoacidosis and all those things will be discussed in the further chapters. For urine for protein and microalbumin, urine for protein is usually done to exclude any infections that are present in the urine. So how to perform a glucose tolerance test? That is glucose tolerance test. We have discussed in the previous slide. That is the patient which patient to test is plasma glucose, and patient having uncertainty of diagnosis of diabetes, and fasting plasma glucose is around 110 to 126. In these patients, oral glucose tolerance test is usually given, and preparation is patient is given unrestricted carbohydrate diet for at least 3 days, and overnight fasting for at least 8 hours should be taken by the patient, and 30 minutes rest, because there is no activity of the patient within the 30 minutes, and there should not be any smoking. So it also impairs the glucose test. So patient before plasma glucose and 2 hours after the over glucose 75 glucose load, the blood is taken. So impaired is fasting glucose is if it is 110 to 125, it is called impaired. Less than 126 is less than 126, less than 110 is normal, or diabetes is more than 126 fasting, and more than 200 is post load, that is after 2 hours of glucose load is fasting, that is diabetic. So how do you clinically judge? That is symptoms of thirst, polyuria, nocturia, and rapid weight loss are prominent in type 1 diabetes. And most of the patients of type 2 have vague non-specific symptoms such as chronic fatigue, malaise. And some patients of uncontrolled diabetes is associated with increased susceptibility to infections, and patients may present with skin sepsis, boils, such as genital candidiasis and pruritus valvae and balanitis. So these some present with complications due to these susceptibility to infections. So they present with infections. So what is the differentiation features between type 1 and type 2 diabetes mellitus? So what is the typical age of onset of type 1 diabetes? It is usually less than 40 years of age, whereas type 2 diabetes is more than 50 years of age. And duration of symptoms, usually in type 1 diabetes, they manifest early. That is within weeks of onset of diabetes, they present as, and these patients mostly present with type 1 diabetes, most commonly present as a casualty with diabetic ketoacidosis. Whereas type 2, they manifest after months to years after the onset of symptoms. And body weight, type 1 diabetes patients are usually lean or normal built, whereas type 2 diabetes are obese. Whereas in type 1, the ketonuria is present, whereas in type 2, it is present in some cases, not all cases. But rapid death without treatment with insulin, yes, in type 1, because in type 1 only insulin is the treatment of choice, and in type 2 we can try them on oral hypoglycemic drugs. So autoantibodies are usually present in type 1 diabetes mellitus. So so only the cases of type 1 diabetes mellitus will be associated with other autoimmune diseases, whereas they are negative in type 2 diabetes mellitus. And complications at the time of diagnosis, no, there won't be any complication at the time of diagnosis. That is, microvascular and macrovascular complications are mostly will not be present in the patients with type 1 diabetes, whereas 25% of the 25% of the type 2 diabetes mellitus patients will have complications at the time of diagnosis. And family history may or may not present in patients with type 1 diabetes mellitus, whereas they are present in type 2 diabetes mellitus. And other autoimmune diseases usually present in type 1, whether they are uncommon in type 2. So after the distinguish, while there is while there is a clear-cut distinction, there may be some overlap of symptoms between age of onset, symptoms, duration symptoms, and family history. And pancreatic antibodies are detected in high titers in type 1 diabetes mellitus, and physical signs in patients with type 2 diabetes mellitus at diagnosis depends on mode of presentation. So they presented the OPD with some type of symptoms, and where they present to casualty with other symptoms. So what are the management? So first is, what are the aims of the management of diabetes? One is to increase the one is to improve the symptoms of hyperglycemia. That is, patient should be relieved of that polyuria, um, um, increase its thirst and polyphagia, and the weight loss should be cut short. And you should also minimize the risk of long-term microvascular and macrovascular complications. And the treatment to diabetes includes dietary and lifestyle modifications, oral anti-diabetic drugs. These include many classes, that is bigonides, sulfonamides, and newer oral hypoglycemic drugs such as DPP4 inhibitors, SGLP1 inhibitors, and all those things, and injected therapies. These are mostly injected therapies include insulin, that is short acting, ultra short acting, and long acting insulins. So in addition to diabetes, in treating hyperglycemia, other risk factors for complications of diabetes that include hypertension, dyslipidemia, and also alcoholic and smoking cessation should be given prior importance for along with the treatment of diabetes. Then uh, coming to diagnosis by treatment. Before treatment, you should first educate the patient. This is usually done in a multidisciplinary team. That is, it includes a one doctor, one dietitian, one specialist nurse, and a podiatrist. Podiatrist for foot care, and all those things in a outpatient settings. So every time the patient when comes to the for a checkup, he has to be seen by a doctor, and a doctor followed by a dietitian and a nurse to check the other parameters to BP and all those things, and a podiatrist to for foot care, checking of the foot care. So these patients, if in patients of diabetic neuropathy, there will be increase. There will be chances of injuries that are being missed by the patient for detecting. So these injuries, they get infected and causes increase in the diabetic levels. So leading to diabetic ketoacidosis and all those things. So every time you have to explain the patient according to foot care, and you should also explain the patient about the dietary habits, and you should explain the patient how properly and at what timing you should take the medication and all those things, and everything and uh, lifestyle modification, everything should be, you should educate the patient. And coming to self assessment and control of glycemic control. So in people with type 2 diabetes, there is not usually a need for regular self-assessment of blood glucose, unless patient, if there is a self-assessment is most commonly given in patients with who are on insulin, or the patients who are taking sulfonylureas, because there is risk of getting hypoglycemia on with patients taking sulfonylureas. And the patients who are insulin treated should be taught how to monitor their own blood glucose using capillary glucometers, that is blood glucose meters, that are glucometers that are we usually use in the wards for detecting for monitoring of diabetes. So the patient should be advised how to use these glucometers, and the patient should be advised before the starting of diabetes, oral hypoglycemic drugs, and other injectable insulins and all those things. The patient should be advised regarding what are the what signs will be present if the patient develop hypoglycemia, and how to monitor hypoglycemia in the at home, at a home setting, and what are the things to be done, and how to measure the blood glucose levels using a glucometers. Next, coming to diabetes and driving, the main risk is usually getting hypoglycemia. That is the patients, the driver, after while doing driving, if he he takes the tablet and skips the meals, or takes an insulin, but the meal quantity is usually inappropriate. So there is every chance of these patients going into hypoglycemia. So insulin treated diabetic drivers and the drivers who are on diabetic drugs should be advised to check blood glucose before driving and 2 hourly in during long journeys. And they should be kept an accessible supply of fast acting carbohydrate in the vehicle. Ask them to take regular snacks and meals. Stop driving if any signs of hypoglycemia develops. Refrain from driving 45 minutes after treatment of hypoglycemia. And carry identification in case of injury. So every time you should get a identification card with him along. Then coming to what are long-term supervision of diabetes. So as it is a complex disorder and it progresses with time. So you ask the patient to come at regular intervals to check for any hypoglycemic to check their glycemic levels. So the patient diabetic glucose level should be kept monitored at at a regular interval, that is any one month visit or 2 months visit. So when there are at normal levels, so the patients will be there will decrease chance of going into microvascular complications and macrovascular complications. So how do you review a patient? When the patient reviews the diabetic clinic, you should check for any lifestyle issues. You should check how is the general health of the patient, how is his general condition at work or work, or any smoking activity, amount of alcohol intake, any stresses or depression, how long he is doing an exercise and all those things, and body weight and BMI, because obesity, mostly central obesity, causes most commonly insulin resistance. So you should advise the patient, or you should educate the patient regarding the risks of obesity and risks of insulin resistance that will be developing in these patients. And every checkup you should check for blood pressure, and should be ideally kept at 130 by 70 or 140 by 80 maximum. 130 to 140 is systolic blood pressure, and 70 to 80 is diastolic blood pressure. And urine analysis, you should be checked for any presence of urine, any presence of glucose, ketones, albumin, and any micro or macro albumin, both micro and macro albuminuria. Most commonly, before the macroalbuminuria occurs, three years before the macroalbuminuria occurs, microalbuminuria will be detected in the blood. So then you should check for biochemistry such as renal, liver, and thyroid function, lipid profile, and estimated 10-year cardiovascular risk to guide the need for lipid lowering drugs. That is, statins are usually checked. Glycemic control, HbA1c, that is, it gives a value of three months duration. So it should be HbA1c should be checked for once in 3 months. So hypoglycemic episodes, you should inquire the patient regarding number of hypoglycemic episodes he had, and what is the cause of hypoglycemic episodes they each visit, because it may be the drug which you have given may be more to the patients. So because the individual body constituency will be different, so the patients will have hypoglycemia because of drug. Second thing, because of skippage of meals after drug, and all those things, and all things should be assessed. So again, you should also examine the sites of insulin treatment. So at the sites, whether there is any infection to the site where they are being injected the insulin, and all those things, and what are the method they are doing, how they are doing. So sometimes at the site of injection, the lipodystrophy occurs. So the patients on diabetes should be screened for any diabetic complication, early diabetic complications. So once in 6 months, the patient is usually once in 6 months, eye checkup should be done to rule out any changes of diabetic retinopathy and all those things. And foot care should be given and should be checked every day, every visit, to skip for any unnoticed injuries. So what is the management? So ideal management includes allow the person to lead a completely normal life, remain symptom free, and achieve normal metabolic state, and to escape long-term complications of diabetes. Regardless the etiology, the choice of treatment is determined by the adequacy of residual beta cell function. So once the beta cell function is normal, you will keep the patients on oral hypoglycemic drugs. If the patient having complete loss of beta cell function, then you have to give them complete dependence on insulin. So what is about diet and lifestyle modification? So what are the aims of dietary management? So the aims include it achieve good glycemic control, and the aim and the other aim is to reduce the hyperglycemia and avoid hypoglycemia, and assist in weight management. Management usually were weight management for overweight patients and obese type 2 is different, and weight maintenance for type 1 diabetes and non-obese type 2 diabetes is different, and reduce the chances of risks of micro and vascular complications, and then ensure adequate nutritional intake and avoid atherogenic diets or those that aggravate complications, that is high protein intake in nephropathy and all those things. So what should be the dietary constituents of these patients? Because it should conclude, it should contain carbohydrate only 45 to 60%, whereas sucrose is up to 10%, and the total fat is less than 35%, out of which polyunsaturated is less than 10%, whereas monosaturated is 10 to 20%, and saturated is less than 10%. Protein should be in 10 to 15% of the 10 to 15%, but should not exceed 1 gram per kg body weight per day. Fruits and vegetables are given 5 portions daily. And weight management, the lifestyle interventions or pharmacotherapy that it includes obese. As there is weight reduction, there will be decreased chance of HbA1c. So most of the diabetics, as there are obese and there is central obesity, they should advise regarding weight management, and they should be encouraged for weight loss. Some of the surgical procedures such as liposuction, bariatric surgery, and all those things are being followed for any reduction in weight, banding is, and all those things. And long-term benefits in terms of glycemic control and microvascular have not been adequately assessed. Even though there is reduction in weight, the chances of getting the microvascular complications are mostly not assessed clearly. So exercise. Patients with diabetes should be advised to have regular physical activity and to maintain this in the long term. They also help to maintain insulin secretion because the exercise causes increase in insulin secretion and hence the decreased chance of getting complications due to diabetes. So the patients usually it is advised, this exercise is usually advised for those are type 2 diabetes mellitus, because and in type 1 diabetes if exercise occurs, there is exercise does not cause any weak, because insulin secretion is not there in type 1. So it is usually advised in type 2 diabetes mellitus. And alcohol has both positive as well as negative effects. The positive effect is the alcohol decreases the chances of getting hypoglycemia in these patients, and the negative effect is it affects the liver and all those things. So the liver and hypoglycemia, there is increases the glucose synthesis, glucose metabolism in the liver is affected, leading to hypoglycemia again. So what are the first line drugs that are usually given? So the first line options is usually metformin, which is sulfonylurea is usually given. Metformin is usually the first line drug you start in the is metformin, and if the patient is intolerant to metformin, then sulfonylurea is usually given, that is glibenclamide and all those things. If the patient having if the glucose levels are not controlled even with a single drug, then an add-on drug is usually given. It forms a sulfonylurea along with the DPP4 inhibitor or thiazolidine. So usually if there is no hypoglycemia, if hypoglycemia is not a concern and there is no cardiac failure, thiazolidines are usually given. If there is hypoglycemia is a concern and weight gain is a concern, then DPP4 inhibitors are given. So in followed by, and if at all the glucose is also not controlled with two drugs, then it should be add on with a DPP4 inhibit, this metformin plus sulfonylurea plus DPP4 inhibitor or insulin with GLP-1 agonist. So these are the treatment options that are given. So this is the outline for treatment of diabetes. In your next class, you will be taught about the oral hypoglycemic drugs, their mechanisms of action, their side effects, and all those things, and how do you manage the side effects. Until now, there are any doubts?
No, sir.
No doubts. So if there are no doubts, we will close the session now.